Right. Can you see this? Am I sharing the screen with
Yeah.
Oh, I love it.
you? Huh?
That's
Hello.
amazing.
You got it?
Yes.
I've got yeah.
Great. Okay. Right. So how do I stop sharing now? There you go.
You can keep it on that from now, I think. Like, you might as well. Because I think we're going to start letting people in a minute.
Okay. What happens? Will someone tell me when to start?
Yeah, Andrew's just going to introduce you, and then he'll hand over. So he'll start everything.
Okay. So do you want me to just get on?
Yeah, leave it as just a backdrop, and yeah, it'll just be a few words. Like, he's not gonna.
Okay.
Not gonna waste everyone's time.
I'm not gonna drag on. It'll literally just be 1 or 2 words.
Will they see me talking or just this screen or what?
They'll see you talking as well.
They'll see that little picture of me.
Yeah.
Okay, and you guys. Oh, brilliant. Okay, that's nice. And can you see my mouse moving on the screen?
Yeah.
Great, because there's some things I want to point out. So I'll actually change it to pen and pen color. And then I can underline things and point. That would be great. And will it be interactive? So if anyone says anything, they can actually talk to me?
It depends how you want to run it. Like, what we usually have is just so it can stick to however long you want to have it, we have people put the questions in the chat box, and then at the end we can like read them out to you. But if you we'll say that at the start to remind people, and we can leave the questions till the end if that's what works.
Yeah. If something comes up during the questions that you are is relevant to a slide or what I'm talking about, then do ask me. Do interrupt, please, because it's much nicer.
Sure.
So I thought I'd get this slide background, which is topical really for today.
So we've got a few people waiting now. Shall I start letting them in? You happy to start?
Yeah, go for it, Nancy.
Okay, cool. Slower.
unmuted بس مش شايفة حد هو كده.
لازم تفضلي ميوت.
هما عملوني unmuted.
مش تدوسي تاني
فين اعملها منين muted؟
Hi everyone, thank you for joining. We're just waiting for a few more people to join us, then we'll start. Thank you for waiting. Hi everyone, so we'll make a start now. Thank you for everyone who's joined us and happy Halloween. We're glad you can all join us for our third lecture today. I'm very excited to present our lecturer, Dr. Wail Girgis, who will be talking about implants. Just a quick note on our fundraising. So far we've managed to raise around £25,000, which is half of our target for our mobile dental clinic. So we're nearly there, and we just need help with the donations. So if you can spread the word about it, and we'll be sending out an email link with the GoFundMe page. So if you could spread the GoFundMe link as well and try and get as many donations, then we'll manage to get there. But thank you all very much for joining us today, and I'll hand over to Dr. Wail.
Thank you very much, Andrew. Firstly, I thought I'd get the slides quite topical for today's talk, being it's Halloween, and so our slide background is a pumpkin with a tooth. So I'm very, very pleased and honoured that you guys asked me to speak for such a sort of wonderful organisation. Now today's little chat is going to be Only Diamonds Are Forever, which is the old James Bond film, which is quite topical, unfortunately, because of Sean Connery, who died unfortunately today. This obviously isn't me, this is Sean Connery, but I thought it'd be appropriate to have him up there because he looks far better than I do. So thank you very much. I'm very honoured to talk for such a wonderful organisation. So today's objectives, or tonight's objectives, aims, objectives, really to look at cases where implants have gone wrong. This is happening more and more at the moment, actually, because a lot of people are getting into implants. I've seen this over the past few years, and really we want to talk about how do we manage failures? What do we do? How do we avoid the complications of placements and avoid the pitfalls? And really talk about planning. How and where does it start? And one thing I always have in my mind is it's only by working at what you can't do that you turn into the expert that you want to become. It's all about purposeful practice and just continuing doing what you want to do and what you love to do. But also, a little caveat with that is with help, expert help and guidance, mentorship. It's no good just doing something that you see with the hope that it will work. You've got to have guidance and learn as you go ahead. So one question is, why do people get into implants? I've seen a lot of people getting into courses very quickly. Is it just because of the money aspect, which is always the wrong reason to do anything, or is it a viable treatment option? And we'll see in this lecture, maybe some treatments were not ideal. Jim Quick is a motivational speaker, and he says, do what you love. Find the love in what you do, and you'll be able to do that. And you'll find 5 days to every week. It's basically enjoy what you do every day. If you don't, you find something about it that you do enjoy. And I love what I do because you're helping people, much like this organisation. So really, when do complications happen? Is it in the past, present, or future? And really, I think the complications actually start at the planning stage before the knife has gone into the gingiva, before you've placed the implants, because it might not happen on that day, but it's a domino effect. Later on, the problems actually appear. So it happens right at the beginning. But where does the fault lie? I've seen and I've heard a lot of dentists and a lot of patients say, my implant's failed, or a dentist saying, your implant has failed. You know, where does the blame go? And people are too quick to blame others, which is a terrible state in which we're in at the moment. There's not as much help as there should be for people. And patients like this. Now, this is 3 weeks ago. A patient came into my practice and said, could you just re-cement my implant bridge, please? This is obviously the implant bridge, and these are the implants that have come out. And there was one here as well that's still in the mouth, which is no longer there. And the whole restoration was failing. So there's a basic misunderstanding of what can be achieved. And it's terrible to see this sort of thing. It really upsets me, especially for the patient, because this is his upper jaw. And too many teeth missing in one go. So these complications happen in many, many areas. And if I were to be honest, I think the biggest one of these is clinician factors. It's us, really. We cause the problems most of the times. And I'll go on to show you and explain that. I'm not putting people down. I'm just saying that it's mainly all in our hands, and we have to do everything we can to build in success in our treatment. So implant failure is basically the failure of the implant to fulfill its purpose due to many other factors, which we'll move into. So does the implant actually fail? Or do we fail the implants? I think we want to turn it on its head, really. Are we failing the actual implants? You know, it's easy to find faults, but to do better may be difficult. People always appropriate blame on others, but you don't know how difficult it was at the time to do this, treatment. So could we do better? Maybe we couldn't. And also, I think it's very important to be mindful of the laws. This is wonderful. I think this is really funny. The law of the instrument, Maslow's hammer. Basically what it says is, it's tempting if the only tool you have is a hammer, treat everything as if it were a nail. If you're an implantologist, the only thing you think about in a gap is an implant, and that isn't necessarily so, as shown by the next slide. Now this chap must have thought, well, why not? I can stick one implant per tooth, and even in some implants, let's have one implant per root. Not great at all. And this is a slide I call, if you first don't succeed, try and try again to get that implant in. And just for Halloween, I thought I'd get one of the Freddy Krueger masks in. This is just, I don't know what's happening here, but we're seeing more and more of this around the world. So it's not ideal. This I just got off Instagram recently, actually. I thought I'd put it in, about an implant that is in the eye. I don't quite know why they had to draw arrows to tell us where it is. That's pretty obvious, but it's actually a paper from the Maxillofacial Journal from January. So things like this are happening around the world, which is quite sad, really. So what are the variables? What are the things that can go wrong? Could be the time of day, morning or afternoon. This is about us clinically treating. Are we better in the morning, some in the afternoon? I remember a patient saying to me, as they're booking their implant appointment, should I book in the morning or should I book in the afternoon? When are you best? And I just couldn't believe that, but maybe, you know, this is how they're thinking, and it's sort of true. Are we in peak condition or not? Do we have external factors? Are we under mental stress that affect our treatment? Was it a previous dental extraction just before our implant placement? Are we tired? You know, are we running late? So we have to rush. You know, is it our training or education? Are we trained enough to do the procedure that we are treating, or is it the implant that's at fault? Which is the only constant? The only constant here is the implant. That never changes. Everything else can change. So I put it to you, is it the implant that fails? Or is it us that fails the implant? Look at this lovely little implant here. I mean, I find this quite amazing. This takes skill to actually put an implant in at this direction where there's a tooth here. And then it takes even more skill to restore it like this. This little implant's working incredibly hard to support this little crown. It's amazing. I think that's the operator, not the implant that's at fault. So when does the implant lose integration? Whose fault is it? Is it actually about blame, or should we actually just try and fix the situation? That some are just outright failures, right from the beginning. Now here again, we've got 1, 2, 3, 4 implants. And at this point, the operator could not have thought, great, I've done a brilliant job. Look at this, great implants. There's no excuse for this sort of thing. So we're going to split it up into, I call it the 5 Ps of implant problems: planning, placement, peri-implantitis, which everybody I think knows about nowadays, perioperative complications, and patient aftercare. And every now and again, I'll just throw a little picture like this, which just shows amazing treatments from across the world. So planning, I think Benjamin Franklin's quote is amazing. Failure to plan is planning to fail. Right at the beginning, things can go wrong. I think education is the key to understanding the principles and therefore executing treatment. You have to be educated. You have to be mentored properly. There are too many of these very quick 2-day courses, sell you an implant kit, and people are just going in and placing implants. So there's everything's rushing on. It's all about speed. Everyone wants everything immediately. And I think we just have to slow down really and actually do what's right and not be pressed by the patient into doing things too quickly. Now, poor planning, we see things like this all the time. I mean, this case here, the implant looks like it's too palatal, but if it were actually placed a little bit deeper up here, then the emergence profile wouldn't be too bad. But things like this as well, you know, you only had one place to put that implant, and unfortunately it was just too distal. So there are many, many areas. Now, general case planning, this is a case that was actually sent to me saying, please, could you help? Because I've tried to re-cemented this crown on these 2 implants. There's connected crowns on 2 implants. They keep falling off. Please, would you see if you could cement them permanently? And this is how the patient came in, with crowns in his hands. So I had a look, did an occlusal check, and this is how he bites together. This is occlusion. You can see this over-exaggerated curve of speed. There's this abutment here. And I thought, well, actually, the referral letter says 2 implants. I can only see 1. This is the abutment that comes out, and it's off at a weird angle. And also, it's contacting the lower tooth. There's absolutely no room for the crown to be re-cemented. And this is the side view. Just couldn't understand what was going on, so I took an X-ray, and there's only 1 implant. So I asked the patient what's happened. There should be 2 implants here. He said, oh, by the time I got to see you from the referral letter, 1 implant fell out. So we're left with this situation, which this was no good. So this was removed. And then we took a CT scan to see what it was like after healing. And you can see absolutely incredibly minimal bone there to place further implants. The referring dentist said, please, could you put in some more implants? Absolutely not. There's no way. This is another law. This is the same principle of, he saw a space, must put an implant in. Whereas I would say this sort of treatment for me, I mean, I'm an implantologist, but I'd be looking at a cobalt chrome denture, because this is a full reconstruction waiting to happen. And if the patient can't afford it, there are other means than restoring with an implant. Implants are not the way to go most of the time. So this is one situation where an implant can only go in one place only, dead center. There's one gap, that's all there is. It has to go dead center. And I think a lot of the time it's dentist positioning. This looks like this was done from the left-sided implant, person standing on the right-hand side. Visually, it looks okay because it's screw retained, because the screw hole will come here, but it's way too close to this tooth. So this thin, tiny bit of bone that's between the implant and the tooth would just disappear in time. Again here, these 2 implants placed too closely just to minimize and prevent the sinus lift happening, because here's the sinus lining here. So trying to squeeze 2 implants into a situation where really this implant could go back here with a sinus lift, again, training or referral to a more experienced practitioner. But we have a problem here where there is bone at the time of placement, but as time goes on, the bone shrinks. It's being constricted. There's no blood supply to it. We're also looking at the emergence profile. As dentists, as the implantologist, you place the implant in the correct position, then you ask the lab to create your crown. And with that, you have to explain the dimensions and the positioning of every aspect of the crown, even the emergence profile. So it's nice and smooth. So a patient can clean, they can floss around this area without collecting food, and therefore contribute to the health of the implant, much like these smooth emergence profiles. Not like this, where you have this sort of 90-degree ledge. That's incredibly difficult for a patient to clean, and you just worry about what's going to happen down here long term. This is a situation where you have a tooth. If you just concentrate on the angle of this tooth here, so every implant that's placed should be relatively in the same sort of position. So that's the first implant, not too bad, maybe a little bit too buccal. There's a lot of bone palatally that's missing. The next implant, we're looking a little bit off again. And then the third implant, it just doesn't get any worse than that. These are useless. The teeth are supposed to be down here, and implants are placed at these ridiculous angles. So this is quite sad for the patients, because they go through, they save up an awful lot of money. They put trust in people, And this is what happens, which is a shame. And again, situations like this where there are, the same law applies. A space, try and put in too many implants. They're too close. There's way too many implants in these sort of areas, much like here. I think you remember this from earlier on. It's that picture. So we've got these sort of implants placed too closely. We could effectively have missed this one out. We don't need that implant. But again, this comes down to planning and diagnostic planning. Same law applies. This crops up again and again, which is why I find that law quite funny, really. Situations like this, I don't actually know how these sort of things come to play, where implants are placed at this direction and then at this angle, and then this can't be used, this isn't even covered, and then restored. I feel quite bad for the patients because cleaning is impossible in situations like this. And also here, where two implants are way too close, trying to get an impression of both of these is going to be almost impossible. Much like this situation, an implant is placed, you put it in, and then when it comes to taking the impression, it's important. You have to adjust the impression coping. In this situation, you have to have the confidence to say, actually, I just can't use this. We're going to have to remove it, let everything heal, and then start again, because this is just in the wrong position. You'll never get a crown in there that fits. Also, with planning, you need to be able to make sure patients clean as nice as this. I mean, this is quite a miracle because the implants are way too close, but it's beautifully clean. And we're quite lucky with this sort of patient that oral health is maintained. However, this looks like an implantologist placed these implants from the right-hand side, a right-handed dentist standing on the right-hand side, and each implant beautifully parallel, but they're off pointing to the wrong direction. But that's not what I really wanted to show you. If I take a close-up shot of this, looking at the fit of the framework, which doesn't fit particularly well, but look at the bone level. We're lucky in this situation. Sometimes it works, sometimes it doesn't. This bridge, this is a patient that comes into our practice that we've seen. This is a very, very old style bridge on extremely old Brannemark type implants. It's over 20 years old. And this lady is about 80, 85 years old, but the bone level still remains very, very good for her, for the condition that we're in. But the oral hygiene is not that good compared to something like this, where you have these Straumann implants that are designed with a polished collar that are designed to maintain health. But look at the bone response. It's shocking, completely different. And this is what happens. You cannot guarantee that one implant is better than the other. And here's the x-rays that's showing just complete and total bone loss around these implants. So we're looking at long-term maintenance and looking at cleansability. Do we really need to squeeze this many implants into a dentition? We don't. You know, we could miss out every other implant. There are techniques now where we do full arch immediate loading on just 4 implants, maintaining the health and cleanliness of the patient. Yet again, there's that law again. It applies here as well. But remember, the most important thing, not every gap is a titanium deficiency. There's other ways of filling gaps in the mouth besides an implant. And that's why the whole patient care, you have to be trained looking at a patient as a whole, not get fixed onto Maslow's law. So this, again, a patient walked into my practice saying, can you please re-cement or put my implant crown back? And this is completely the wrong way of planning. You don't usually have 3 teeth or 1 implant. You should have 2 implants with 3 teeth on it as a normal conventional bridge. But this is what we got. Unfortunately, the implant had failed, so we didn't put that in. We're back into a denture for the time being. But again, too few. This little implant here is working incredibly hard to support this massive crown. And really, you know, should we have 2 implants in there? Well, maybe move this implant, plan it so it's over here with a single premolar tooth and have a 2 millimeter gap that's self-cleansing in this area. It comes back to planning every single time. And this just wasn't planned correctly because there's a space, so we put an implant dead center. Not the right way of going about things. So this here, this quote relates to this sort of picture. Hope is the desire of the soul to be convinced that the dream will come true. Some dentists thought that they were hoping their dream of restoring this implant would come true. It doesn't work. Much like this little implant. It hopes it will work, but it won't. And I just thought every now and again I'll throw in a picture of lovely Cambridge, where we are. This is one of the colleges. And I thought this was quite funny that poor placement is also in Cambridge, because no one in Cambridge places their bike next to a college door, because Cambridge is the theft capital of the world for bikes. That would get stolen. That's a case of poor placement. So the other situation with poor placement is vital structures. We want to miss ID canals, the lingual vessels, things that are terrible. Then we have a situation like this. Now, the poor placement is not because of this here, where we've got two implants almost touching and bone loss in between, but really down here, what's going on in this area here? Well, that's an implant in the nerve, in the inferior alveolar nerve. And we have a study from Dow in '98 showing the damage that can be caused by improper implant treatments. And I've got Rafiq to thank for the next slide, because we have this implant that's gone straight through the mandible, straight through the ID bundle, causing anesthesia. Now, I could pretty much think I can understand why that means a short implant. Maybe they were hoping to miss the nerve, but in this implant here, it's long, it's too long, it's too big. I have no idea why this has happened. And even in this situation, I mean, this takes amazing skill. Why is this implant in the ID bundle at that direction? I don't even know how that's got there. Again, I took this from some social media pictures. I was just shocked at how this can be happening. The next patient, this poor chap. This is a true story, quite a famous person, really, a sportsman who had an implant placed in what we thought was a healed site, or maybe was it socket shield. Don't know if you've heard of a socket shield technique where you partly remove the tooth, leaving the buccal surface of the tooth in place to maintain the buccal bone, and you place the implant palatally to it. This is not what I mean by buccal socket shield. So they just didn't remove the implant and ended up, the tooth, and ended up putting the implant in this sort of area, down the root of this 6. Now, long term, what's happened is that this was removed, and the patient lost the 6 as well, which is just awful. And the next one I saw was this, what I call a piggyback implant theory. An implant's gone too far, so what do? Just put one piggyback on top of it. It's amazing what you see after many, many years of implant placement. And this looks like quite a good implant placement here, so I don't quite understand what's going on here. But when it comes to making mistakes, you've got to be smart enough to realize your mistake, secure enough to admit it, and strong enough to fix. Everybody makes mistakes. It's good just to put your hand up and say, I'm sorry, but we'll get it fixed. There's another way of doing this. Now, the other problem with poor placement is jaw fractures. Again, this is an old slide with when we used to do bicortical fixation of implants. So you fixate against the cortical plate up here and the cortical plate down here. But in thin mandibles, this is what can happen. And this was a Godacre review in 1999. Very rare nowadays. The next thing I have been referred is this, an implant in the sinus, where a dentist has placed the implant, it's popped into the sinus, unfortunately. Instead of dealing with it, it was just left there. And it was actually left there for 7 years because they just put a new implant in there, which was wider, that was stable, everything left as it was. Now, the problem with having an implant in this sort of area, the fact that rubble rattles around, can also get infected. And with this, you have to do a lateral window to get it out. So if this is going to happen, please, please, I always say to people we teach, you've almost got to be a little bit better than the procedure that you're doing, because if anything goes wrong, you need to be able to fix it straight away, or actually have someone close by that you can refer to fix it. So poor planning equals poor placement and therefore poor results. So it always starts right at the beginning, at the placement. Now this again, I took off media because I thought, well, this doesn't look too bad. But then you look at the cross section of the CT and you think, well, that's a little bit too buccal. You know, that's not great. But then you see the clinical shots and you start losing bone and then start losing gingiva. And this is just going to get continuously worse. They could get infected, then you lose bone. This is a case that I was referred again. This is one of my students that came to me from the Midlands and said, look, could you help please? I got my mentor to help place this implant and it's in this sort of area. So we had a look at it from different angles. He said, is there any way of restoring this? And there absolutely was not any way of restoring this, not even with an angled screw channel, because this was rubbing against the tongue. And you say, well, did you not use a surgical guide? Yes, they did. This was the surgical guide that was used, and you can see this implant completely away from the surgical guide. So I don't know what happened. That shows just how severe it was. So there's no way we could use this. This is the clinical shot in the mouth. And it's also too high. It's not deep enough because that's the implant there, that's cover screw. So we've already exposed the implant during healing, not even loading. So what do? We've made a new surgical guide because I just didn't trust the old one. And in these situations, we use an implant removal tool of a fully integrated implant and remove it. We just have to remove it. There's no way we can treat it. So there's a screw that screws into the implant, torques into it, and then another screw that screws on the outside of the implant and holds the outside of the implant and then derotates it out of the jaw. And thankfully, it removed very nice. You can see here it was about 11.5mm length implant. And then what we did was placed another one. And I always draw pencil lines on the mouth showing where the nerve is, where the edge of the tooth in front was, so no one gets blinkered into implant placement. They know exactly where it's going to go. Again, use the surgical guide to confirm exactly where it is and place the implant exactly where we want it to be for screw retention. And then we grafted the deficiency from the other implant. So luck. Is it luck? No, luck is the last wish of those who believe that success can happen by accident. We should have no luck in implantology or surgery in any way. It should be planned and it should be executed properly. So which brings me on to guided surgery. This is something that can help us. Now, this is a case, a lovely, lovely lady who was, how old was she? About 87 years old. She's got an implant retained bridge here, this single incisor, and these teeth here. This bridge was carious. She did not want to have a denture. She's got an anterior occlusion only, not even premolarized. It was canine-ized. And she didn't want a denture. She refused to have a denture. So we thought, okay, what we might do is just immediately load this. There's no posterior support, everything's anteriorly, so it's a bit of a risk, but to get this properly immediately loaded, these implants had to be as parallel as possible, and they went around the arch from the fore to the central. So I used a surgical, planned it on Simplants, got a surgical guide ready, and this is my template, my surgical guide as well, and my template for the bridge. Extracted the teeth. We did immediate placement, so that's the guide in place to make sure that we are in the right position. Implants placed according to the surgical guide, and lo and behold, perfectly screw retained for the temporary bridge that we're going to make. And those are the implant analogues with the temporary abutments. And what we did was they made sure that fitted and then filled in with composites around this area to make sure it was beautifully smooth and to maintain the gingiva. We also did a lot of graftings. That's why we've got this flap here. And that's underway for restoration at the moment. And that's worked very nicely, thank goodness. There's other forms of guided surgery, which is floss. I couldn't believe this. Is this actually guided surgery? No, it's not. This is luck. But there are other ways of computer-aided planning and placement. We use a CBCT, we convert the DICOM data to, there's lots of different software, Simplant, Noble Clinician, Co-Diagnostics from Straumann, SMOP, Blue Sky Bio. Any of these are great. We just happen to use Simplant because I like the functionality of it. It works beautifully for us, and we've been using it for many, many years, but all of them are great. But is fully guided surgery the way to go? Can you rely on it? Now, there have been studies done with fully guided surgery techniques, and we found that even with the CBCT planning, there are significant deviations. You know, there's this angular deviation of 7.9 degrees. There's deviation apically of 2 millimeters. Various studies will show this. Again, there's an error of 1.24 millimeters at the apex, and the range is huge. I have to say that's massive for apical deviation. It's because these guides do have a little bit of play in them, and you just have to be aware of that. It's a guide. You still have to use clinical judgment. You can't turn your mind off when you're doing this. You've still got to have everything about you and know what you're doing beforehand. So it is not an easy way of putting implants in. Zhu's paper in 2018 was great because, again, it shows the issues that we might have with discrepancies with guided surgery. It's still a guide. So there's a friend of mine, Leon Parente, who said to me, this is guided surgery, not blinded surgery. No one would work like this. So why do we when we have a guide? We don't. You still have to be very careful even by using it. And the next stage of guided surgery is this X guide that's being sold by Nobel, where it's, to me, I looked at it, and I'm a wet-handed clinician. I've come from the old school where we didn't even have CBCT scans for implant placements. So you had to, you made a lot of mistakes, and you had to learn by your mistakes. And we're trying to prevent that from happening. But I think this is taking us a little bit away from surgery and being really involved with the patient. It's great, it's amazing, but I don't want to dumb down people's experience. They still have to learn how to do things. So this is a way of planning on CBCT, where to put the implants. And this machine here, you have a handpiece with a toggle on here, and in the mouth there's another toggle in here that relates the two positions, and you see on the screen, I call it PlayStation Dentistry, you see on the screen exactly where your implant is. You actually look on the screen, you don't look in the patient's mouth. And as you tilt your handpiece, you'll see here where you're going, and it'll go red if you're going too deep or you're off at an angle. It's just like PlayStation Dentistry for me. I found it very difficult to use because I'm more of a direct vision type of guy. But then the evolution, this was amazing. 2017, a robot in China did the first successful implant surgery without human intervention. Look at this. I mean, personally, I wouldn't maybe go for this, but this is the way things are happening. So is that the evolution? I don't know. I don't know. Maybe I'm too old. Maybe I'm a dinosaur, but I like this sort of technique where we know what I want to do, where the implant's going to go. I take a CBCT scan, we do a diagnostic wax up, I get a surgical guide made, and I place the implants according to the teeth. And it's predictable. I know what the bone's like. I've got the teeth to be screw retained. It's predictable. We're in control. I like to be in control of things. Even for full arch cases for implant retained dentures, we have this beautifully healthy jaw. We've got our guides made from Simplants, razor flap, put the guide in place, and it is actually very, very firm indeed. And just drill the holes. Now, the good thing about this is that if I had not planned this and we just lifted the flap, I wouldn't have noticed this beforehand. And on the day of treatment, then I'd have to work around it. Because we did the surgical guide, we did the CBCT planning, I knew this was here. So we'd planned these implants specifically because this gap, all the planning, all the worry was taken out of it. So it was quite a simple procedure. And then we make the final restoration and everything works beautifully. So next, peri-implantitis. I just thought I'd throw a picture of the Cambridge rowing team. I think they won last year. So peri-implantitis. The scientific approach versus the practice approach. Is it different? What are we actually going to do? And these are implants that have just lost bone. Now, personally, I get in a lot quicker than leaving them till they get to this stage, because you lose bone and there's no hope of doing anything. So it's a plaque-induced pathological condition. It's bacterial-based. Same flora as the periodontally involved tooth. And the problem is with it, once it starts, it is very difficult to prevent it. And it doesn't mean it affects every implant in the mouth. We've had implants where they're generally very healthy, and one implant out of the 3 just fails because of bone loss. The symptoms are bleeding or probing, there's pus, maybe if there's mobility, the implant's had it. But you can tell, you can see the gingiva starts looking quite bad around it. So it's what to do. It's really what to do with this situation. There's lots of ways we can try to repair the bone loss. Medications that you can use. There's detoxifying the implant surface, flap, tetracycline, cleaning the surface. One of my partners even drills the surface of the implant away to make it as smooth as possible. A colleague of mine, a very good friend of mine, they use water laser to help them. They seem to get great response from that. But what the questions you really need to ask is, how do I treat it? Should I be treating it? When should I take the implant out? You know, how much bone loss am I prepared to put up with? Or can I rebuild it? So this is a case that was donated by one of the colleagues in practice, which reminds me very much of the Lion King, the circle of life. This is the circle of an implant's life. So that's the position where you want to place an implant. An implant was placed, it was restored, everything looked good for a couple of years. Then we started seeing a little bit of bone loss around the edges. It continued. You know, we hit this with everything, dentamycin, hygiene, cleaned it as much as we could, but it just didn't stop. It continued, and then we're back at the beginning again, but this time with less bone. Now, could it have been occlusal? People say occlusal aspect causes overloading, causes bone loss, but it wasn't. This tooth is the back tooth. That's the heavy contact on that. That's all protected. Was that the end of the story? Well, no. A sinus lift was done, a new implant was placed, and again, cement retained. And that seems to be functioning well. Why? I have no idea. To be honest with you, it just seems to be working well. So there's the CIST protocol where you mechanically clean, you improve the oral hygiene, you remove the deposits, use antiseptic therapy, rinse, antibiotic therapy, surgical therapy, or then remove. It's a segmental approach to treating. In situations like this, you've got to be really brave to treat that because you've already lost an awful lot of bone, even around the teeth. But we have new strategies. There's an instrument called the Galvosurg, which is promoted by Nobel, and the airflow, which is now being promoted by Straumann. Now, the Galvosurg is just being released, actually. It's been released, I think, a week ago from Nobel, where it's an electrolyte liquid that is sprayed around the implant. So basically, a low voltage activation causes hydrogen bubbles. And these bubbles are supposed to break away the biofilm. They're showing good results. We have 4 airflow units in our practice to remove the biofilm, again using 14 micron powder to clean the surface. And again, that seems to be working very nicely in some cases. Now the Galvosurg, this is the equipment, and this is what happens to the implant surface. Whether it actually works or not, I don't know. The studies are showing great results. I haven't used it myself, but we are certainly looking forward to getting it. And the airflow, the EMS, we are using a lot. It's called guided biofilm therapy. And that seems very nice indeed. That's getting to the implant surfaces. And we've seen a couple of cases that have peri-implantitis. The gingiva seems to tighten up. It looks good. So we hope. But then there's the cement-induced peri-implantitis, where cement has been placed in cement-retained crowns, just too much, and it goes underneath. And then this is what happens. You get bone loss underneath the gingiva. If you're using a cement-retained restoration, you have to take a PA every time afterwards to make sure there's no cement afterwards. Or you get a situation that looks like this, where you get this sort of look around the gingiva and then lifting a flap showing bone loss because of this, a lot of cement. That's the PA of it. In this situation here, trying to minimize, there's ways of trying to minimize the cement by making a little indice of the abutment, putting cement in it, get the excess out, and then placing that on the implant. Or actually, why use cement at all? I haven't done a cement retained crown in about a decade. There's no need. You know, there's lots of screw retained options. And now you have angled screw channel for implants up to 25 degrees. This is the Nobel version, this is the NEOS version, this is the Straumann version. Atlantis do it, everybody does angulated screw channel. So that can be used for anyone. There's no need to use cement anymore. So we have post-op complications moving along, because I know I don't want to keep you guys up for too long tonight. Now, I don't judge people by the colour of their skin. It's a bad thing. Judge them by the colour of their teeth. That's what I always say. Post-op complications, we want to think about occlusal aspects, positional, the aesthetics. I'm going to show you a few cases now that we've done, that have come to us, the ones that we call a bad day in the office, which are these. When you have the abutment fracturing, zirconia abutment. We don't use zirconia much anymore in the abutment aspect. It's a titanium base, but with zirconia on top. This is a bad day in practice when a patient comes in like this. All the implants have failed and just come out. All this is a point of no return. You just can't help. This was referred to me from a colleague who said, please, can you take this out and put an implant here? But I thought, what's going on there? Can you send me a couple of PAs? And this is what they sent me. This was done by someone else. Problem here is that that's narrower than that, 2 different types of implants. This is higher than that. The emergence profile is wrong. So if I start doing, and obviously there's bone loss around here. If I start treating this, which is right next door to this, I'm incorporating this and I'm accepting this. So if anything goes wrong from my point onwards, it's my fault. So you have to point out these problems well before you start treatment. Here, unknown bone loss. We've got this area here, bone loss in between, just with these three implants. So what do? Just take one out and everything's stabilized. Why there was 3 implants in the first place, I don't know. Remember that law. Situations like this, positioning of implants on the day of placement, you need a surgical guide, otherwise this is what happens. And the result is not particularly good at all. Implants placed too buccally. This is a chap that came to me, one of my cases, that said, please, could you repair my implant? I don't like the look of it. This is his smile line. So he has a low smile line, but didn't accept this because the implant was just placed too buccally. Because it was too buccal, it lost bone and lost gingiva. And this is the PA. This isn't peri-implantitis. This is just bone loss from the fact that the bone was too thin. It just resorbed. So this is what he was. This is how he ended up. We've rebuilt him. Now this is where he was. We took that out. We let everything heal, conventional, put a new implant in, did some soft tissue surgery, got the gingiva back to normal. And then long term, everything's healing quite nicely. So just getting things carefully placed in the right way, it works very nicely. This is a case where implants were placed to replace these lowers, too buccal. And you'll see exactly why it happened afterwards. Impressions were taken. You can even see during the temporary phase of the temporary denture, these implants are way too buccal. You should know at this stage something is wrong. But they were restored. It's fine. They were restored. Didn't look good. This is why the implant was placed too buccal. This is the lingual wall. This is the buccal wall, and this is the cortical plate. And this cortical plate has effectively allowed the drill or the drill to be placed too buccal because this is quite tough bone. And this is what happened. You lose bone straight away. So what happened was that this implant was drilled off. It was actually removed with a burr, with a high-speed diamond, and just left. But then you lose bone next door. It's a domino effect. Things are just being lost. So what happened? They restored it. It was removed. 2 implants were placed. You see how deep these are placed now. So they've got teeth and they had to use an awful lot of pink porcelain. Is this fixed? I don't think so. I think this is a poor result. The cleaning is awful. This part of the implant's placed. So you don't compound problem upon problem. Sometimes you just put your hand up and say, I've made a mistake. This is one of my own cases where this tooth had fractured down the middle. So we decided to remove it, let it heal. Let it heal for a few months, 3-4 months. We placed a lovely NEOS implant in there. Looked good. It healed beautifully, bone beyond the implants, took the impression. Everything was lovely until this point where I torqued the crown down, the implant failed. And I removed it. And why was that? That was my own stupidity, because this tooth here was the cause of the issue. Poor root filling. And if we look all the way back to maybe this picture here, you see that radiolucency? When I took the implant out and I cleaned the socket, I found a little tunnel this way here, a little soft tissue sinus. It went to the point of here. So it was a latent infection, just infected my implant, my own fault. So this has now gone to retreatment. What I should have done was had that assessed by the root treatment specialist beforehand. This was, again, a mentored case that was asked, please could you help, because this implant just is exposed and it just wasn't done right. It's too vertical. Basically, this implant is a very long implant that was used to tense the gingiva to hold the bone graft, which never worked. This is it. It's not infected. The bone just disappeared. This is all bone graft material, xenograft. So again, just remove the implant with a removal tool. We had to. This is a handy little tool here because it sits over the implant and stops the implant from breaking, the top of the implant from flowering. And it was removed, just unscrewed, a fully integrated 15mm long implant. See the threads? Beautiful bone, beautiful integration, but just not in the right position. So took it out, re-prepared it, placed it in the proper position with a little bit more grafting, and then sealed. And I was lucky enough for the gentleman to send me an X-ray when he took the impressions for the final restoration months later, and bone level's beautiful. So very happy. So fractured implants, the drive is generally useless. We don't want to remove the implant and create trauma, and we don't want it to fracture. So we like this. So we just use this Neodent implant removal tool. Use that every time. Every implant with an internal thread can be removed with this tool. It's a great tool. I don't want to use these trephines to drill away bone and remove the implant. So this situation here is a case of joining implants and teeth. Not a great move, really, because they have different movements. Implant doesn't move, and we've got the periodontal ligament around the tooth. Now, this is a situation where an old gentleman came in, and the implant was maintained here, but this is a carious tooth. It just decayed away because it became de-cemented and became carious. And this is what happened, it fell off. This is the tooth that was underneath, it became carious. This is the core vent implant, and none of it really fitted particularly well. So what do we do? Just remove it. Remove the tooth and connected the two new implants to the other implants. I didn't want to remove that implant at all, but kept it in place. This is during the healing stage. The problem was this was an all-in-one type of abutment. I couldn't remove it. So this was sitting there by itself. So to temporize, we just made a denture, the little hole that fitted right through there. And he was happy like that during the healing phase. But then the other side of the mouth, the same thing started to happen. Same problem, implants to teeth, caries. Now this was a legal case, unfortunately, that was sent to me to say, please could you help? This lady had deciduous canines. Someone had started Flapless, had treated the patient with Flapless surgery. So not lifting a flap to place the implants, which is a recognized technique, but you still have to be careful. And she said, this area is continuously irritating. It hurts, even when she touches it. This was the deciduous tooth that was bonded onto these teeth as a temporary. So I took a CT scan and look what happened. The deciduous tooth was removed, the implant was placed at the same sitting, but straight into the root space. And it's outside of the bone, completely outside. So we had to raise a flap. This is what the implant looked like. Just can't save it. So we removed the bone. And this is how lovely this kit is, because removing the implants carefully, derotating it, that very, very thin layer of bone was maintained just there. So what we did, had my surgical guide, pencil lines where that root is where the implant needs to go. The implant was placed properly, grafted to build up the missing bone, membrane, and then placed all back. We even gained a little bit of gingiva, thank goodness. And this is the final result. So that's the right-hand side, centrally placed, which is quite nice. Happy with that. This is the left-hand side, which we didn't replace. We accepted that implant, but I wish I had taken that out and replaced it because of the next view. That's the one we did. That's the one we accepted because that's just too big. She's not happy still, the lady. She's accepted the crowns, but she's not happy because of the gaps that are appearing there. And there's another patient that came to me saying, had this implant placed. The dentist said, look, we did it flapless. It's all gone wrong. I can see why. This is the CBCT again, just outside of the bone. So I put it on this implant, planned it, and funnily enough, I could get an implant in bone behind the implant that was already in the mouth. Crazy. So that's it, and we got them screw retained. So we did exactly that. I removed the bridge, placed the implants, immediately loaded them, all at the same time, and it seemed to be okay, thank goodness. From there to there, just by planning it properly. Now this came again to us saying, 2010 this was, pushing that envelope, I call it, with these two crowns were loose, please could you re-cement? And I said, okay, but this confused me because I thought, well, these are zirconia implants and I don't understand why I couldn't see a screw in them. And then I touched these and they were actually mobile. The gingiva is healthy, there's no infection, and they just unscrewed. Pure zirconia implants, just unscrewed. They were all in one. So these were placed, drilled for a crown, and the crowns were made. No infection at all. On the x-ray, this is what they look on x-ray. Bone looks beautifully healthy. They just didn't integrate. So we just went back to basic principles, took them out, let everything heal, 2 implants, perfect. Two crowns, and have been stable ever since. So patient aftercare. Now, the most important thing I find about patient aftercare is George Bernard Shaw's quote that the single biggest problem in communication is the illusion that it has taken place. Now, I communicate with my patients about aftercare, and I think that I've had that conversation, but I just worry that it hasn't actually happened because you get situations like this. Just, what didn't, was it my fault? I don't know. Or maybe they didn't listen. This is what we need. Now, this is a very difficult situation where you think this is going to be awful to clean, but actually the patient is doing incredibly well, really very well indeed. So aftercare, we've got to just make sure that patient is taken care of. Planning is important, and when you finish the treatment, how they take care of it long term. That would be their fault if they don't. That's the only time when I think it's the patient's fault. So patient aftercare, maintain it in many ways, and we have to educate them in that way. But I'm always going back to my single prayer, my Serenity Prayer is basically, God grant me the serenity to accept things I cannot change. Some people just can't be changed. I must have the courage to change the things I can, so help people as much as I can, and the wisdom to know the difference. And nowadays, I'm at this stage where I think I'm going to protect everyone every single time with a Michigan splint for all my treatments, because I just, this for me is part education of them. If they wear this, they're compliant, and I stand a better chance of success. So with that, I'd like to say thank you very much for listening, everyone. Thank you very much to the Coptic Dental Society for having me on this very late night on Halloween, when you should be enjoying yourself. And I hope I've sent everyone to sleep and have a good night's sleep. So thank you very much for listening. Back to you guys.
Thank you very much, Dr. Girgis. We appreciate your time. It was a very interesting and informative lecture.
Thank you.
Dr. Girgis is a lecturer in the Eastman Dental Institute, and it's one of the most prestigious postgraduate dental teaching hospitals in the UK. So appreciate the time you've taken to give us your lecture, especially seeing as implants are becoming more and more commonplace in general practice. We just have a few questions here on the chat. I think John has a question. He's asking, is there any case where you would not use surgical guides?
No. Well, I've got to be, if I'm being absolutely truthful, now, I mean, I've been doing implants for over 25 years, and there are some cases that I now don't use surgical guides. but there's always ways of knowing if you're in the right place. There's the rest of the mouth. So you've got the adjacent teeth, you've got the occlusion where the lower teeth bite into, you know where the screw goes. So I think the more experienced you are, then yeah, I don't use them all the time. But when we're teaching, when you're learning, I think making a very simple acrylic guide is the least that you should be doing, just to help placement. People get tunnel vision when they're doing implants. So all they can see is the drill and that bit of bone. So you can go off at these really strange angles because you don't see what's around you. That's why I use pencil lines all the time when we're teaching as well. But no, I mean, I think get into good habits right at the beginning. Use a guide. I hope that answers it.
Yeah, it does. Thank you. One from William as well. Do you believe there is a fixed criteria that can classify failure for all placed implants, or is it just based on the clinician's own assessment or what they believe failure is?
Failure is something that no longer fits its purpose. So whether it is the shade of the crown or a chip in the porcelain or the implant being lost, I think there's been many criteria being written about failures, and failures are endless. But I think if you're talking about how to diagnose it or how to describe it, I think there are criteria in place. I don't know them, but I think you've just got to accept it with the patient. If the patient doesn't accept it, it's a failure, and that's something you need to go. So there's many different levels of failure, from the minimal to the most horrendous, which is surgical.
Thank you. I've got one of my own questions. How do you remove a poorly placed implant that's fully osseointegrated?
That's what I tried to show with that implant removal tool, that Neodent removal tool. All the implants that I've removed are fully integrated. That tool is for fully integrated implants. The ones that aren't, you just pick out. So that screws into the implant, the middle screw, you torque it to about 70, 80 Newton centimeters. Then the Trefine looking instrument screws on top in the opposite direction, and that derotates the implant out. And that works very nicely indeed on every internally screwed implant.
Thank you.
Minimal trauma.
Okay. Rafiq's asking, what is the hygiene recall for implant patients?
I assess in different ways. If it's a single implant, then we place the implant, then we'll try and get them, we'll go through the cleaning, we'll try and get them in a month later to assess how they're clean, and then tell them what we would advise in terms of monthly recall. Sometimes it's 6 months, sometimes it's 3. You can only advise, and it's for them to book it. With the full arch immediate loading, during the temporary phase, we've done the surgery, immediately load a full arch. Then I have a hygiene 1 month later, then every other month during the 6-month healing. And then afterwards, we fit the final restoration. We leave them 2 weeks, get a hygiene appointment, and then we do it at 3 monthly. Now with that, we will assess their cleaning, and then we'll say either come in more often or you can leave it. But once a year, we'd advise the patient to come in to have the full arch bridge removed. We clean it in the lab while they have hygiene to clean around the implants, then we replace it so we can see what's going on.
Brilliant, thank you. I think Dr. Masiha would like to make a couple of comments.
Sure.
Do you want to join us?
Yes, thank you very much. Brilliant lecture, Dr. Girgis. I work at St. George's.
I used to work there myself.
Max Fac surgeon, yeah.
I was there. I was at St. George's for years.
Well, we should really get together. Well, an excellent lecture, I must say. Fantastic choice of cases, and I must say the first few were very much related to Halloween. I don't know how you kept up with the flow of some horrendous cases you've dealt with, and having such fantastic results that you showed at the end. One comment and one question. Risk score index. I've been working on a risk score index for implants, and I looked at tooth annotation, general health score, and poor quality of bone or bone quality. And certainly I know the dentist or implant surgeon factors you've highlighted very smartly. I think we've not alluded on the diabetes, smoking, immune suppression, radiotherapy, and so on. So the comments. The question is on the Galvosurg and the biofilm therapy, whether you would remove the superstructure and close the gums over it while you've done some bone augmentation and membrane treatment for the ones you're trying to salvage. What's your views?
Thank you. Firstly, with your comments, absolutely agree. This was more of a horror show type of situation than a medical issue, so I couldn't include everything. I was even worried about putting peri-implantitis in there, but I thought, well, why not? So thank you very much for your comments. You're absolutely right. With the Galvosurg, we haven't got that yet. We're planning on buying it. The airflow we're using, but we're using that at the moment with the superstructure on in areas that we can get to. You remember the slides that I showed with the emergence profile?
Yes.
If the emergence profile is correctly done, you're able to probe, you're able to get into those areas, and we can. There's a case of mine that I've taken on that I've actually just removed the superstructure completely, put a healing abutment on, and then we're using airflow around it and cleaning, and on repeated visits every 2 weeks to see the resolution. If we get resolution, I'm not bone grafting, I'm not lifting up, because I don't think if I remove the gingiva and graft that surface, that titanium roughened surface, that I'm going to get anything stable on there. So what I'm trying to do is just remove the pocket depth, reduce the pocket depth, and actually get the gingiva tighter so nothing else gets down there, and accepting the fact that there might be some recession.
Okay.
I think with me, in my limited experience with that, you know, I would rather, if it's getting to that stage, remove the implant completely and say, right, let's rebuild, and then tent it, build up some bone with either a bone block or titanium reinforced membrane or Zyphos membrane from Geistlix, cover it completely, and then rebuild bone that way, and then start again. But
yeah.
I'm just worried about rebuilding bone around an infected implant. I don't think I'll get it clean.
I think you're absolutely right when it comes to recognizing the failure early and call it the ace of spades, and remove the implant and deal with the situation rather than carry on making a wider hole for yourself. And the other comment that was nice was that you've made was on the 5 Ps, and I thought maybe it should be 7 Ps with four patient choice and patient factors in there. So yes, lovely lecture. Really thoroughly enjoyed it, and thanks very much everyone. Dr. Girgis to join you.
Thank you.
Thank you.
I think nowadays there's too much blame going around. I think we've got to help each other. Some people, we all make mistakes. Everybody does. We've got to help people not to make mistakes, and when they do, instead of blaming them, help people. That's what this organization is about. You help people, you teach people, you guide them. That's what we've got to do. Yeah.
By the way, that implant that you have horizontally on the ID bundle, a very similar case came to me while I was at George's, and was like an implant. It was. And this particular, I always tell that story and show a similar slide, exactly the same. And the surgeon, actually, the implantologist, dropped it on the lingual side.
Yes.
The while drilling, it went lingually, and it was undercut with the mylohyoid ridge, and it was lying over the mylohyoid muscle. Horizontally. So it shows the advantage of doing 2 views, because there's just no way anyone could even do a 90.
Exactly. That's what I thought. There's got to be lingually placed, so it's gone through the lingual plate, because you can.
Yes.
We have to create more trouble.
Incision to get hold of it, but that's as you said, was poor planning and not understanding the anatomy of the lingual side with an undercut.
Yeah, people just don't. I think, like you, we come from an era where there wasn't this use of CBCTs. You learnt by other means And now with the CI, we scan every patient. So it should, implant treatment should become more predictable and safer. But we're seeing more and more issues, and that doesn't make sense to me. So either people are just not bothering, not caring, which is really sad, or not being trained.
No, absolutely. I don't want to take too much more time because I could talk to you for ages.
I'd love to.
Well done. Well done. Thoroughly enjoyed it.
Thank you, sir. It's an honor. That amazing that you, for someone like of your stature, to say that. Thank you. I'm humbled. It's lovely.
Thanks very much.
Thank you very much, Dr. Masiha. We've got one more question. So, are implant scalers useless, and what do you recommend?
Implants. Sorry, what was that?
Implant scalers.
Yeah.
Are they useless or not?
There are titanium scalers called the Suvan scalers. The only problem with implant scalers that were in the past, because now it's been superseded with all these other instruments, they were too big. They were quite thick. They were plastic type materials that were too big to get into the area. And now the metal scalers, what you don't want to be doing is scratching the surface of the implants. And then there's the whole question about should you probe or should you scale around implants. But now we've got, the airflow, other methods of cleaning around an implant. So I think personally in our practice, we used to have implant scalers that you very carefully went around the implant. We don't use them anymore because there's no need. So we've gone away from them.
Thank you. Well, what do you think of the newer techniques like photodynamic therapy and things like that?
I haven't had any experience in that, I've got to be honest. I know a colleague of mine does use that sort of, and they say, they swear by it. But, again, it's case selection, I think.
I think that's all the questions. Thank you very much again for speaking for us today.
Pleasure, absolute honour. Thank you so much.
John's just posted the link for the GoFundMe page. So if anyone who wants to donate, or if you want to send that link around, then please feel free. And we'll see you again soon for our next lecture. Thank you again.
Thank you. Good night, everyone.
Thank you.